Right, so we said 4 basic tissues: epithelium, connective tissue, nerve, muscle. Then under connective tissue, we said we further divide the connective tissue into connective tissue proper, which we said as loose connective tissue and dense connective tissue. Then we have fluid connective tissue, where we have blood and lymph. Then we have structural connective tissue, where we talk about cartilage and bone. Right. So structural connective tissue is where we have cartilage and bone. So it's easy to describe them side by side. Right. So we have characteristics that we ascribe to these things, right? So you'd find that your cartilage and bone, they're similar to the soft connective tissues, where you have cells, fibers, and the ground substance. Remember, I said there's a living component, which is the cellular component, and there's a non-living component, which is secreted by the living component, where we have the protein fibers. Then we also have the amorphous substance, which is the ground substance, where you're going to have all those things, right? So what is cartilage? Right. Cartilage is an avascular tissue. So cartilage doesn't have blood vessels. It's an avascular tissue that is made up of, or that consists of, cells that are known as chondrocytes, right? So they have chondrocytes and an extensive extracellular matrix, right? So more than 95% of your cartilage, or the cartilage volume, is made up of extracellular matrix, right? Then the chondrocytes for cartilage, they are located in matrix surrounded spaces, or little pockets of spaces that you then find within your extracellular matrix, which we'll now call lacunae. When I get to bone, osteocytes, which is to bone now, they will also reside in lacunae, whereas osteoclasts, they reside in a specific lacunae, which we call house-shaped lacunae, or resorption cavities. Then the type of collagen, or the structural protein that is most abundant in cartilage, is type 2 collagen. We usually used to say cartilage, whereas in bone, if you remove the word B from bone, we are left with 1. So bone normally has type 1 collagen. But for cartilage, then again, we have different types of cartilage. So it's not correct to just say it's type 2 collagen. For example, fibrocartilage, we'll talk about type 1, but here we're just mentioning the predominant collagen, right? Then the ground substance, it doesn't change. Used to have multi-adhesive glycoproteins, used to have all those things, right? So you're going to have proteoglycans, you're going to have hyaluronic acid, you name it, right? Then we said cartilage is avascular. It is no nerve supply. Remember, epithelium was avascular, but it was highly innervated. But for cartilage, it is avascular and has no nerve supply. And if something is avascular, it's going to heal slowly. Why? Because you need a good blood supply for you to have proper healing, right? Then, since it's also avascular, you need somewhere where the nutrients and the oxygen are going to come from. So they come from something that surrounds it, which we call perichondrous cartilage. So perichondrium is going to be a dense, irregular connective tissue. That's where you're going to have supply for all those things, right? Then again, still there, I want to talk about cartilage growth. So cartilage grows either by appositional growth or interstitial growth. Whereas when you look at bone is only going to grow via one way, which is your appositional growth. So how does this happen? Interstitial growth, you're going to have mitosis of pre-existing cells. But when it's appositional growth, there's migration of stem cells from the perichondrium that are going to, or basically your fibroblasts that are within the perichondrium, that are going to differentiate into chondroblasts. That's appositional growth. But when you look at these types of fibrocartilage. Fibrocartilage will lack a perichondrium, so then you can't expect fibrocartilage to have appositional growth. Instead, it's only going to undergo interstitial growth. Whereas the other two types of cartilage that I'm going to talk about, which is hyaline cartilage and elastic cartilage, they're going to be able to undergo both appositional and interstitial growth. Right. So this is the slide that shows you that. Maybe it's kind of bad to show a slide then talk about it when you're staying there, you won't listen. So this is the slide that talks about growth of cartilage. So we have three types of cells mostly in cartilage: chondrocytes and chondroblasts. Remember, I said chondrocytes reside in lacunae or spaces that you find within the extracellular matrix. Extracellular matrix is the one that is that covers almost 95% or is 95% of the volume that you have within your cartilage. So these are the other components of cartilage. There's ground substance. Then there's also the fibers, which I said it's going to be type 2 collagen mostly. So these are chondrocytes in lacunae, those cavities there. Right. Then the covering, it's perichondrium. The perichondrium will have an inner layer and an outer layer. Remember, perichondrium, I said it's dense, irregular connective tissue. The inner layer is the one that is cellular, which has chondrogenic cells that can give rise to new cartilage via appositional growth. Then the outer layer is a bit fibrous. And this perichondrium, we said it is absent in fibrocartilage. So since perichondrium is absent in fibrocartilage, you then cannot say that fibrocartilage can undergo appositional growth. Right. So it can then undergo things like interstitial growth, where there is mitosis of pre-existing cells. Right. So these are the methods of growth of cartilage. There is interstitial, then we have appositional. During interstitial growth, a single group of cells that are coming from a common chondrocyte after mitosis, they create something called an isogenous group. Right, so this is just a cell with its various daughter cells following mitosis. Right. So these are isogenous aggregates. I think you can see this nest of cells located in one region. These are cells that are growing by interstitial growth, but they all came from one cell. So the mitosis is happening there. Right. Then appositional growth, we say there's migration of the cells from the perichondrium, then they differentiate into chondrocytes. Right. So we have three cartilage types. We have hyaline cartilage, which is mostly type 2 collagen fibers with the ground substance, the glycosaminoglycans, the proteoglycans, and the multi-adhesive glycoproteins. Then we have elastic cartilage, where we have elastic fibers, because remember the types of fibers that we have: elastic, reticular, and collagen. So elastic cartilage, you have those elastic fibers. Then fibrocartilage. Fibrocartilage is a bit unique. It's a bit different from the rest of the two types that I've mentioned above, where fibrocartilage, instead of having more of type 2 collagen, it is type 1 collagen. Remember, I said type 1 is for bone. If you remove B on bone, it's now 1. Right. Is that a question?
Okay. Yeah, it was a question. So why is it no one of my fibroblast akawanda ari pa type 1 collagen you ifanda kwanika iri pa bone?
By fibroblast, what do you mean?
You said fibroblasts I'm usually made up of type 1 collagen. So I'm saying why is it so? And then you said or fibrocartilage. Okay, yeah. Okay, I get you now.
Okay. Then yeah, so hyaline cartilage is mostly type 2 collagen. That's what we find on most articular surfaces for joints. I'm sure you've done a lot of synovial joints where you now say they're covered, the articular surfaces are covered by hyaline cartilage. That's a typical synovial joint. But there are certain joints in the body where they're going to be synovial, but their articular surfaces are covered by fibrocartilage. Those are the joints that you call atypical synovial joints. For example, the sternoclavicular joint and your acromioclavicular joint. Their articular surfaces is going to be fibrocartilage, but they're synovial in nature. That makes them atypical. But a typical synovial joint is almost always going to have hyaline cartilage coating its articular surfaces. Then there's some hyaline cartilage in the trachea. When you do respiratory, I'm sure you'll find that the trachea is made up of 15 to 20 C-shaped rings of cartilage. The costal cartilages that connect the rib to the sternum, that's hyaline cartilage as well. I'm just mentioning a few examples, right?
Yes.
Then we said hyaline cartilage can grow by both appositional and interstitial growth, right? Elastic cartilage, it's so I usually say E for E. Elastic ear. So it's there in the ear, it's there in the epiglottis. So notice it's E for ear. So this one, the perichondrium is present. It can grow by both appositional and interstitial growth, as opposed to fibrocartilage, where I said fibrocartilage will only grow by interstitial growth only. Why is fibrocartilage growing by interstitial growth only? It lacks a perichondrium. For you to be able to have appositional growth, you need migration of those chondrogenic cells from the perichondrium. What is perichondrium? Perichondrium is the dense, irregular connective tissue that surrounds cartilage. And that is also where the nutrients and the oxygen will come from the blood vessels that are within it. So coming back to hyaline cartilage now. Hyaline cartilage, I said it is a perichondrium, right? But when you go to a joint, for example, a synovial joint, we have synovial fluid. Synovial fluid is a filtrate of plasma, meaning those things are there, the oxygen and the nutrients. So you don't need a perichondrium. You don't need a perichondrium at your articular cartilage. You won't have perichondrium, right? So hyaline cartilage has perichondrium, yes, but when you find hyaline cartilage lining joint surfaces for a synovial joint, there will be no perichondrium because those things, the nutrients and the oxygen, will simply come from the synovial fluid that is bathing the joint. Right. Okay. Then remember I said cartilage is avascular, so repair is slow, and there's a low metabolic rate because of poor oxygenation and blood supply. Right. Then, on the other hand, now, bone is also structural connective tissue, but it is characterized by an extracellular matrix that is mineralized. You now talk about calcium, calcium hydroxyapatite, calcium phosphate, you name it, right? So bone is also a specialized form of connective tissue that will also have cells. It will also have an extracellular matrix. The cells in bone, you have osteocytes. So the prefix osteo, we use it on bone. So osteocytes, osteoblasts, and osteoclasts. Then function-wise, bones are going to do to have protection, support. They act as levers for muscle. That therefore movement. They store ions like calcium as well, right? And most of the calcium you find that it's actually in your bone, right? These are the characteristics of bone. One thing that I'll point out here is, unlike cartilage, which was avascular, bone is actually highly vascularized. we have blood supply in your bone. Right? And I'm sure even when you do your gross anatomy, you talk about nutrient arteries. So nutrient arteries are those that are going towards bone. For example, your brachial artery, when you do your upper limb, your brachial artery will give rise to a nutrient artery that goes into the humerus. Those are the arteries that supply bone. Right. Then remember I said
certain you said the cartilage are not avascular and they are also not innervated. Yeah,
cartilage,
just moving.
Cartilage is avascular and it's not innervated.
Yeah, so how do they function if they are not vasculated and if they are not innervated?
So it is, I say that there is a perichondrium where the blood vessels are. So the nutrients and the oxygen will diffuse from that perichondrium. Same way epithelium was avascular, but you have diffusion from the lamina propria or the connective tissue that is below your basement membrane. Right?
Yeah. But
okay, great. Then the macroscopic appearance of bone. So we have two types of bone. So macroscopic is what we see by the eye, right? Microscopic becomes the histology. So from what we see from the eye, we have two types of bone. We have what we call compact, then we have what we call spongy. Of course, they have other names, but for the purpose of this talk, let's use compact and spongy. The spongy bone is the irregular plates of bone that you see. If you look at a bone, this irregular part of bone where it looks like it has holes inside, that's your spongy bone. Then this bone that looks dense and solid, which is usually on the outside, that's compact bone. So we call it compact bone or cortical bone. Then the one at the center there, we call it spongy bone or trabecular. Right. So it can be called trabecular bone. Others prefer to say cancellous. Right. Then remember I said cartilage and bone are brothers. So in cartilage, we had perichondrium surrounding the cartilage, right? Which was dense, irregular. For bone, we now have periosteum, also going to be dense, irregular connective tissue. Perichondrium had an inner cellular layer and an outer fibrous layer. It's going to be the same for periosteum. There's going to be an inner cellular layer where there are osteoprogenitor cells to give rise to new bone. Same way cartilage was growing by appositional growth. So bone can undergo appositional growth because there is a periosteum on the outside, which can have cells migrate from it as osteoprogenitor cells to give rise to new bone. Then there's an outer fibrous layer. Right? Then remember bone has a bone marrow. Usually the long bones have bone marrow. So lining the inside now, we'll now talk about something called endoosteum. So periosteum is on the outside, then endoosteum is on the inside. So that's that. Then we say there are types of cells in bone. Before we go to maybe the microscopic structure of bone. So this here talks about periosteum. You can take a screenshot and look at this. This is the same thing that I was saying. Dense connective tissue. They left out to say it's dense irregular connective tissue. Then it's absent as well at articular surfaces because you don't expect those things to be there because they synovial fluid. Then there's something that joins the periosteum to the bone below. What do we call it? The answer is on the page, by the way. What joins the periosteum to bone? We can call them perforating fibers. But But what's the proper term that I'm looking for?
Sharpies fibers.
Sharpies fibers, eh?
Yes.
So we have Sharpies fibers. Then these are the cells that I wanted you to know. We have osteocytes, we have osteoblasts, then we have osteoclasts. Osteoclasts are just monocytes that went to a fancy school. Remember, monocytes become macrophages when they go into the tissues. But then we have certain monocytes that then go to fancy private schools, then they become fancy named cells in certain regions. For example, in the liver, we call them Kupffer cells. In the brain, when we do nerve histology, we call them microglial cells. In bone, we call them osteoclasts. So these are just fancy macrophages. What do? They phagocytose. What do they phagocytose? Whatever they want to destroy. And in this case, bone is actively made, it's actively resorbed. What do I mean by resorbed? You also eat bone. Because when you make bone, you want to make it in the shape of its original position. So when you make new bone, you can make things that are irregular. So to maintain that regularity, you need to be able to have a cell that eats the parts that are irregular or phagocytose them, which is an osteoclast. So one would ask, a macrophage usually has one nucleus, but when you look at osteoclasts, they're described as being multinucleated cells. What does that mean? So when you have an osteoclast eating bone, when you look under the light microscope, they appear multinucleated because they've engulfed some parts of bone and other cells that had nuclei. So they will look like they have many nuclei. So we just then say osteoclasts are multinucleated, though it's not really true. Where do you find osteoclasts? Osteoclasts are found in special types of lacunae, like I mentioned earlier on, that we call house-shaped lacunae. So they're in house-shaped lacunae, which are also called resorption cavities. Why do we call them resorption cavities? It is because in those resorption cavities, that's where they'll be eating bone. So an osteoclast has an apical end, which is in contact with the bone it is eating. So that apical end, we call it a ruffled border. That's where it eats from. Then a basal end where it's just resting from. But in reality, the cell that creates the bone is the osteoblast. So after an osteoblast lays down the bone, it becomes an osteocyte. So an osteocyte is just a mature osteoblast that you now find in a lacunae surrounded by the bone it would have secreted. So osteoblast secretes bone. That osteoblast plus the bony matrix that surrounds it will now make up an osteocyte, which we find in a lacunae. So osteocyte is just in a lacunae. There's no fancy name for it. Same way we said chondrocyte in cartilage is in a lacunae. Osteocyte is just in a lacunae as well, but osteoclast is in a house-shaped lacunae. This is examinable. House-shaped lacunae, also called resorption cavities. Right. Then I said mostly type 1 collagen bone, right? So you just remove B from bone, then you say what?
The B.
1, eh?
Like type 1.
Yeah, great. Then we also talk about Haversian systems, and but like what I want you to know before I talk about Haversian systems. Oh yes, yeah. So maybe this is not a good picture, but microscopically, we have what we call mature bone, then we have what we call immature bone. Immature bone is this woven bone, but mature bone is what we call lamellar bone. I'm sure you've seen a tree before. It is lamellated. So it's something like this. Let me draw. So it's something like this. If you can see the drawing that I'm making. Right. So it will be lamellated. So these are what we call concentric lamellae. Those are concentric lamellae. Right. But at the center there, where I'm putting an X, I call that a central canal. Right. So I will have another lamellae around here with its central canal. So the central canals of these lamellae, they communicate. What do they use to communicate? They have what we call perforating canals. So perforating canals join central canal to central canal. Right. So yeah, so this thing that I've drawn here is what we call an osteon or a Havesian system. Like what was let me clear this and go back to that page where I wanted to show you. Okay. Okay, so a Havesian system or an osteon, it is simply cylindrical units of concentric lamellae around a central canal. So what I drew there, it's what I call an osteon. It's just concentric lamellae around a central canal. What do I have in the central canal? I have the blood vessels, I have the lymphatics. How do central canals communicate? The central canals communicate via perforating canals. Right. And those perforating canals, do you think they have another name?
Perforating canals?
Yes. Do you think they have another name?
The Volkmann's canal.
Volkmann's canals, eh?
Yeah.
Then those Volkmann canals, what do they do?
They connect the Havesian canals with the periosteum.
With the periosteum. What do you expect to be finding in the periosteum?
The bone marrow.
Come on. No. I said bone marrow is inside. Endosteum. Yeah. It's lined by endosteum. What is in the periosteum? It's written on the page. Come on. Blood vessels. Hey. Yes, okay. Blood vessels. Right. Then osteogenesis. So bone in embryology, bone forms through endochondral and or intramembranous ossification, right? I know layman people would just say intramembranous is flat bone, then endochondral is long bones, but that's not really true. But in most cases, it's like that, but that's not really true. Intramembranous ossification is where bone formation happens within a membrane or mesenchyme. Then when it's endochondral, remember chondros is cartilage. Chondrocyte, we saw that in cartilage, chondroblast, cartilage. So where you talk about endochondral, you first make a higher line cartilage model in the shape of the bone that you want to form. Then later you replace the cartilage by forming bone around that shape. And when you form bone, initially that bone will be woven bone, that's immature bone. But that woven bone would then progress to become lamellae bone. Lamellae bone is the one that I said it has those concentric lamellae. Right? So that is the histologic. Sorry?
Which are the parallel sheets? You mentioned that the parallel one.
Parallel sheets.
Yeah.
Where?
In the laminar bone. In the laminar bone.
You mean to say the outer and inner circumferential or whatever layers?
Yeah.
Nah, they're not that important.
Okay.
But histologically, that's the histologic classification of bone. There's immature, which you can call woven or primary bone. Then there's mature, which we can call lamellar bone. Right? Okay. So this is immature bone. So do you think in an adult you can see immature bone? Anyway.
You said what?
Do you think there is any way in the adult body where you can see immature bone?
Yeah, I think so.
So where?
Where you can find immature bone?
Yes.
I just noticed when you said the bones are they're constantly being reabsorbed. So meaning when we are
so when you're forming newborn, So when you're forming newborn, so think about someone who would have had a fracture. Then also in the alveolar tooth sockets, where the teeth sit, there's also immature bone. Then where tendons insert onto bone, there is also immature bone. Right. Okay. I will not describe intramembranous and endochondral ossification. That's embryology, but you get the gist of it, where intramembranous ossification is happening within membranes or mesenchyme. That's embryonic connective tissue. Then endochondral, I lay down the shape of the bone that I want to make in hyaline cartilage. Then I now start to have bone being laid around it. Right. I will not describe that further. Then in terms of growth, bone grows by appositional growth. How does appositional growth happen? Osteoprogenitor cells migrate from the periosteum. Yes, from the periosteum. Same way appositional growth in cartilage was happening from migration from perichondrium.
Yeah, perichondrium. Focus market. Yeah.
Okay. Then differences between bone and cartilage. So bone only grows through appositional growth. Cartilage will grow via both appositional and interstitial growth, with the exception of fibrocartilage. Fibro, I said, it grows only by interstitial. Why? Because fibrocartilage lacks the perichondrium. Right? Okay. Okay. Then osteoclasts, we say they are multinucleated. We've talked about that. Then you can see this cell here. Looks multinucleated. 1, 2, 3, 4. But remember, I say these are just things that you'd have eaten, or things that the macrophage would have eaten. Right. Then bone can repair. It's highly vascular, so repair is quite possible. But something that people fail to quite remember is calcium metabolism. Right. So we have the thyroid gland. The thyroid gland gives us calcitonin. Then we have the parathyroid glands, which give us parathyroid hormone. So what does parathyroid hormone do? Parathyroid hormone, when you do your endocrine physiology, parathyroid hormone will promote reabsorption of calcium in the kidney tubules. It will promote an increase in calcium absorption in the GIT via vitamin D, like making 1,2,5 dihydrocholecalcitriol, whatever. Then, so the point is, parathyroid hormone wants to increase the calcium levels in the blood. So calcium is also stored in bone, because remember when I started, I said bone is a mineralized tissue. So how does it do it? Parathyroid hormone will promote osteoclast activity. When parathyroid hormone promotes osteoclast activity, it's going to cause a lot of bone eating or bone resorption. Then hence you release the calcium into the blood. When calcium is in excess, the thyroid gland produces a hormone called calcitonin from its parafollicular cells. They're different from the main cells that you have in the thyroid. The parafollicular cells within the thyroid will then produce calcitonin. What does calcitonin do? Calcitonin will stimulate bone formation. So osteoblasts now start to lay down the bone. After you lay down the bone, there should be calcification. Your calcium hydroxyapatite. So calcium is now deposited in bone. So calcium metabolism is very, very important. It can be detrimental. Both hypercalcemia and hypocalcemia can have different effects in the body, even relating to CNS as well as the heart, because calcium is contractile, calcium has other functions that it has, right?